All right. Thank you. Thank you for having me. I am so thrilled to be able to talk about something that not only I've been professionally trained to do, but I'm very personally passionate about. As you've heard, I'm a bit of an odd duck. This was my career or research trajectory was not at all planned. I started out in the automotive industry. They kept sending me back to school to do different things. When the automotive industry in 2008 sort of took a downturn, the writing was on the wall that I would be shipped over to Mexico as I was supporting 63 plants in Mexico and another 12 in Brazil. And I thought that it would be a good idea to get some good interview experience. So I started sending out resumes and ended up interviewing with the Division of Occupational and Environmental Medicine at Michigan State University and got the job. And it's really interesting that I'm doing the same work that I was doing in the automotive industry, but sort of on the other side of the fence in a research setting. So my area of expertise actually is exposure assessment. I've struggled for years with the various degrees in trying to determine what to call myself when somebody asks, "What do you do?" And I'd sit there and say, "Well, I don't know." But I would classify myself as an exposure scientist. So what I try to do, particularly with patients with hypersensitivity pneumonitis, is to get out in the field, and quite literally, sometimes I am in the field, collecting samples, doing retrospective exposure assessments, and trying to figure out what it is that these patients are exposed to that's associated with their respiratory symptoms, with their disease. So please stop me at any point in this presentation and ask questions. Okay, so a little bit about hypersensitivity pneumonitis. So the disease is really difficult to diagnose. Oftentimes, before these patients get to me, they've been diagnosed with aspergillosis, they've been diagnosed with sarcoidosis, with asthma, with Sjogren's, and a whole host of other autoimmune diseases and disorders. So that gets to the first bullet, that clinical signs and symptoms are similar to other diseases. So patient evaluation typically includes a complete clinical history, and that's in red because we're going to get into that a little bit later, in the challenges that pulmonologists have, internists have, in actually taking a complete clinical history as it relates to patient exposures. A physical exam, chest x-rays, high-resolution CT scans. These patients will undergo pulmonary function testing. Often, if hypersensitivity pneumonitis is suspected, blood samples will be sent out to run on a standard hypersensitivity pneumonitis panel. They'll have bronchoalveolar lavage performed, and sometimes they'll have a lung biopsy performed. So I should take a step back and mention that for this work that I'm going to describe today, this is actually a National Institutes of Health funded study. It's a 5-year, $3.7 million study to take a look at the utility of a personalized medicine approach to identifying antigen in patients with hypersensitivity pneumonitis. So that's what I'm going to talk a little bit about today, although I'm going to sort of weave a case study around it so that I can sort of drive some of these items home, these concepts home. For my particular study, we have tertiary referral centers across the state. There are 5 of them that refer patients to me to participate in this study. And the diagnostic criteria that we use are these that I'm going to describe right now. So the major criteria for hypersensitivity pneumonitis for participation is that not only diagnosis, but then also participation in our study, is that there needs to be evidence of an exposure to an appropriate antigen from a history or detection of serum antibody. So has this patient been exposed to an antigen that has been associated with hypersensitivity pneumonitis previously? And on immunoassay, do they have an antibody response, a positive antibody response? So let me start out by saying, and sort of keep this locked in your mind as we walk forward through the presentation, that there have been over 300 antigens to date that have been associated with hypersensitivity pneumonitis. And I'm going to ask you, are there any standard panels out there that test 300 or more antigens? Okay, so that's just kind of a hint, right? Okay. They have to have symptoms compatible with hypersensitivity pneumonitis. So that can be wheeze or cough, excess mucus production, shortness of breath. Findings need to be compatible with HP on chest radiographs or high-resolution CT scans. So you'll see indicators of inflammation. You'll see in the medical records indication of ground glass opacities on chest X-ray and HRCT. You'll also possibly see granulomas. The minor criteria for HP include bibasilar rales, decreased diffusing capacity, arterial hypoxemia, either at rest or during exercise, pulmonary histologic changes comparable with HP, a positive natural challenge. So what that means is that if there is a suspected antigen that patient is exposed to, that pulmonologist feels is causal to that person's disease, then if you re-expose that patient to that antigen, they develop symptoms again. And the last item under minor criteria is bronchoalveolar lavage, fluid lymphocytosis, so the presence of lymphatic cells in BAL. So let's talk for a second about the issue with positive natural challenge and hypersensitivity pneumonitis. So with hypersensitivity pneumonitis, particularly in its acute form, if a patient is removed from the environment in which the antigen, the offending antigen is present, then over a period of time, theoretically, their symptoms should go away. So one of the things to note with this disease is that if you're able to identify antigen early on and you're able to eliminate those exposures, these patients should show complete reversal of disease. One of the challenges, and I'll get to this in a minute, is that unlike other respiratory diseases, in response to antigen, whether it be allergy or asthma, oftentimes the initiation of symptoms, of clinical signs and symptoms, are within a somewhat close proximity to when the exposure took place. And because of that, it's often, I shouldn't say it's easy, but it's easier to identify where that exposure was or what the potential inciting antigen was that's related to the development of those symptoms. With hypersensitivity pneumonitis, symptoms can begin 4 to 6 to 12 to 24 to 72 hours after exposure. So when you're working with patients and asking them what they think the exposure was that's relevant to their symptoms, I mean, how many of us can remember yesterday what we had for lunch? Or 3 days ago where we were at 6 p.m.? So this is really a challenge in terms of trying to identify patients and pulmonologists trying to narrow down and hone in on what the source is of the antigen for which they're exposed. Okay, so again, keep that in mind. So how are these patients treated? Primarily with corticosteroids and other immunosuppressant drugs. There's no other way to treat them other than removal of exposure to these antigens. So as you can imagine, the last thing that we want is to have patients on steroids or other immunosuppressants long term, right? Again, the target or the goal is complete removal of the patient from the environment, because once the exposure to the antigen ceases, particularly if they have acute disease, they should be able to reverse the disease process. Yes?
So what if this is, by the time they find out
Yes.
that it really is hypersensitivity
Yes.
pneumonitis,
Yep.
we might be a few years out.
Yes.
So by then, if we remove the antigen, can they have reversal, or is there,
It depends. You like that answer? It depends. So not if they've started to develop fibrosis or scarring. Okay? But our hope with this particular study is that in those patients that have chronic disease, because you are absolutely right, it is maybe 2% of the patients that I see, 2 to 5% of the patients that I see so far. So again, this is a research study, so things will change over time. But at this point, 2 to 5% of the patients that I see have acute hypersensitivity pneumonitis, or what has been classified as acute. Most of those that I see have, when retrospectively, sort of in hindsight, they've been experiencing symptoms for 5 to 10 to 15 years. Okay, so our goal then, at the point that they have chronic disease, is to be able to identify antigen, reduce or eliminate exposures, and hope that their disease becomes stable, stops progressing. Perhaps we're able to diminish the amount of steroids, the dose of steroids, or get them off steroids or other immunosuppressants if we're successful in removing the antigen exposures. So you're absolutely right. It's really challenging with this patient population. So that is one of the things that we're hoping to do through talks such as these. And once the study is completed and we're able to do the analysis and publish the results, we're hoping to get this disease sort of more front of mind as pulmonologists are thinking about their differential diagnoses.
How far are you into the study now?
2 years.
Mm-hmm. Is it 5 years?
Mm-hmm. So we're technically into the study. We're starting our 3rd year, but ramp up and all of that, we've only been recruiting patients for about 2 years. Okay. So again, in review, the disease is difficult to diagnose. The hallmark of diagnosis is identification of the offending antigen in patient disease. Physicians, pulmonologists have a difficult time identifying antigen for several reasons. One, they don't have much time with the patient. And we'll talk about what I do when I go through and try and identify antigen through retrospective exposure assessment. I'm with that patient for a good hour and their family, just talking, trying to figure out what some of the exposures were, the initial exposures that were those that perhaps led to development of disease. They haven't been taught how to conduct exposure assessments and run exposure assessment interviews through no fault of their own. A clinical interview is light years away from an exposure assessment type discussion. They don't have eyes on the ground. They're limited in working with these patients in a clinical setting. And they've got, and here we go again with the standard HP panel results. The only thing that they have available to them to narrow down exposures in terms of confirming an antibody response is utilization of a standard HP panel, hypersensitivity pneumonitis panel. Again, the key treatment is complete removal from exposure. What happens if we're successful in removing patients from these exposures? We see improved outcomes and potential reversal of disease. There have been studies that show that in these patients, there's improved survival if we're able to at least identify what the causal antigen is. Greater around 10 years in those individuals with a positive ID, antigen ID documented in the environment. That doesn't even necessarily mean that we're able to completely avoid the exposures, but just identifying the causal antigen is I don't want to say is enough, because nothing is ever enough, but allows patients to, as best as they can, minimize those exposures. Okay, so what are some antigens of interest? Well, we mentioned that there are over 300 that have been associated with hypersensitivity pneumonitis, and hypersensitivity pneumonitis is called one of a myriad of things. So in farmers that have been diagnosed with hypersensitivity pneumonitis, it's termed farmer's lung. In people that have hypersensitivity pneumonitis that react to bacterium that's in water reservoirs, that's often called air conditioner lung. In patients that have hot tubs or are around hot tubs that react to antigen that's collected from hot tubs, that would be called hot tub lung. So they're not real creative with the naming, but there are a bazillion names for hypersensitivity pneumonitis, and people tend to develop a name based on the type of exposure. So the antigens of interest are typically bacterial and fungal in nature. They can be related to animal proteins. So one of the forms of hypersensitivity pneumonitis is called pigeon breeder's disease. And so there are proteins that are associated with birds that allow for the development or cause the development of hypersensitivity pneumonitis. And then also small molecular weight chemicals have been associated with the development of disease, which is actually how I got involved with hypersensitivity pneumonitis in the automotive setting, because there are bacterium that are associated with metalworking fluids, so in machining operations, and also there are small molecular weight chemicals in various foam, two-part epoxy or two-part polyurethane systems called isocyanates that have been associated with occupational asthma or hypersensitivity pneumonitis. Okay, so this is sort of to illustrate a hypersensitivity pneumonitis panel. So up across the top, and I know this is hard to see, but there are the different companies that offer hypersensitivity pneumonitis standard panels. And down the vertical axis are some of the different antigens that are associated or utilized in those panels. And all this graphic is supposed to show is that depending on the company that your clinical lab refers samples to, you're going to have different antigens on your panel. So we know that there are well over 300 antigens associated with HP. Some HP panels only utilize or only include 3 antigens. Others include 8. And so, what does that tell you in terms of comprehensiveness with regards to antigen panels? And then the second thing to think about before we get into the case study, because that's coming soon, is that if a patient, think about this, patient results come back, and patient and pulmonologist are sitting there and they say, all right, you've got a positive antibody response to thermoactinomyces. Eliminate exposures to thermoactinomyces. Patient says, what is it? Where in my environment is it? How do I eliminate it, right? So that's a challenge. So prevalence of HP, we have, you can see in some of the plain states and some of the northern states, as well as our state, there are increases in prevalence. A lot of that is due to farming. A lot of that, quite frankly, is also due to, you've got National Jewish Hospital in Colorado. You've got some pretty good tertiary referral centers here in our state that know to diagnose HP. It's more front of mind. HP is something that is significantly underdiagnosed. So what does that mean? So 5 to 15% of individuals known to be exposed to an antigen that's associated with HP will develop the disease. And like I mentioned, it's likely an underestimate due to difficulties of diagnosis. So quickly, what do I do? So I go out to the patients. A patient is referred to me. I go to their home or their workplace. I sit down with them and family members if present or if able, and do a retrospective exposure assessment to try and determine what the inciting antigens were that led to the development of disease, because that allows me to try to figure out where in their current environment the exposure may occur. So I collect a bunch of environmental samples. I get blood samples from them. Oops. I will take the blood samples and the environmental samples back to the labs at MSU, run immunoassays, and try and figure out specifically what it is that they're reacting to. And I know I'm getting low on time. With the goal of creating, if we can find an antigen for which they're reacting to, I work with them to develop an exposure avoidance plan. We implement the exposure avoidance plan, and then I track them going forward to see what happens. Does their disease stabilize? Are they able to come off their immunosuppressants? If it was acute disease, are they able to reverse their disease? So, got a patient coming to me. Pulmonologist said she has a bird in the home, or had a bird in the home. We think the suspected exposure was the bird. I go to the patient's home, and that's what I see. Beautiful place, out just gorgeous gardens. Patient is really concerned because she got rid of the bird several months back and she's not had improvement in her symptoms. Now, let me tell you that we know where the bird is. The bird is with a sort of couple times removed relative. So I was actually able to get to the bird and take samples from the bird, which is a whole nother story in and of itself. So this is what I see when I walk in. I sit down with the patient and her family, and we describe her exposure history. One of the best things that you can ask a patient is, when was the last time you felt really good? None of this is rocket science. When was the last time you felt really good? When was the last time you were able to walk around, go hiking, go do whatever your hobby is, or whatever it may be, go to the grocery store and not have shortness of breath, not have a cough? When was the last time that you don't remember waking up in the middle of the night with a cough? Just simple questions. So I do an exposure history, we do a site assessment, so I look around the home, I look around the yard, I listen to the patient tell me what it is that they like to do. What does this patient like to do? Garden, right? We do an environmental assessment and I collect samples, and then like I mentioned, we run immunoassays. So I utilize a questionnaire. I hate questionnaires because they keep you very limited. So I tend to use the questionnaire as sort of a backbone for the questions that I'm asking. But I like to perform or go through sort of circular questioning. So for example, an example of circular questioning, and you're going to see me start moving really fast here. The question of, have you spent a lot of time on a farm? Is a different question from, have you ever spent time on a farm, and in what capacity? Growing up on a farm is different than, oh, well, I was out on a farm for 2 weeks a few years ago. Okay? Remember that question that I asked, when was the last time you felt really good? Okay? It's always helpful to have a family member present, because particularly with patients that have chronic disease, they're not even recognizing their symptoms anymore. But a family member can recognize the fact that, 2 weeks ago, you had a really difficult time just walking out to the end of the driveway to get the mail, when usually that's not the case. Also, the ability to associate symptoms to exposure. Again, we mentioned that sometimes symptoms don't show up for days after the exposure. So in patients where it's difficult to determine the antigen that is relevant, I ask them to keep a log, just a very general log. During, what day is it? What did you do that day? Where did you go? And simply, how did you feel? And I really kind of the next step is to create an app, right? Smiley face, frowny face, nothing real detailed. But what I want them to be able to do, and what I will help them do, is look for those times where there's a frowny face, and then look backwards up to 3 days to see what it is that they did and where they went. And over time, often you start to see a pattern. Oh, and trying to identify inciting exposure. Again, that gets back to when was the last time you felt good? Now that you've been diagnosed, in hindsight, when did you start experiencing symptoms? So I have my patient that had a bird, that has gotten rid of the bird and has had the house remediated. Scrubbed, people have come in and cleaned it from top to bottom. She's not feeling any better. She really likes to garden. She feels a little bit better in the winter, but not a tremendous amount. She does have some scarring in her lungs, so we don't think at this point that she'll be able to reverse disease. Or we know she won't be able to. When talking about inciting exposures, or when was the last time you felt good, she and her husband, or when did you, thinking back, start feeling bad, could be another way to ask the question. She says, first time I really recognized some of these symptoms, and the husband and wife look at each other, was that summer that we were at your brother's house, who had passed away, getting the farm ready for sale. And I said, oh, so tell me about this a little bit. Well, brother had passed away, and they needed to get the house ready for sale. So the patient and her husband spent about 2 weeks on the farm cleaning everything up. There was a silo filled with silage. I don't know if you know what silage is, but it is chopped. It's chopped corn and wheat and stuff that's then essentially fermented and then used as a feed source. Well, there was a bunch of old moldy silage in the silo. So the first week of that 2-week period was spent with her standing in the silo on top of the silage, because she was small enough, shoveling silage out the windows into the waiting bed of the truck below, at which point her husband would drive off, dump it, and then come back. The second week was spent cleaning out chicken coops, hay lofts. Oh, we won't remember him yet. And so again, they spent quite a bit of time doing this. So I said, is it possible, do you think, for me to go to the farm, this is 2 years later, and collect samples? And I said, you know what, we never sold it. It's still part of the family, so absolutely. So I had collected samples all around the home. I collected samples now at the farm. And I went and I found the bird, and I collected samples from the bird. How many of you think that this woman reacted to antigen from the bird? No. Birds don't like it when you come at them with swabs until they realize that you're going to start itching under a wing or something like that. And then they, become a little bit more amenable to it. So again, collected samples, ran immunoassays. This is just a simple picture to show you that we've got various environmental samples in wells around a center well, which is what holds the patient's serum. And over time, antibody diffuses through the gel in an outward direction, and antigen diffuses through the gel in an inward direction, And when the two meet, if there's a response, an antibody response, then you'll see a gray band form. This technique was developed in the 1950s, and there hasn't been anything that's been developed that's better. So it's a lot of work to do this, but it's worthwhile. So here's that patient. Her results on a standard HP panel. What does she test positive to? Anything? You would see it. Okay, you would see an H in that column, a high in that column if she tested positive to anything. So no, she tested positive to nothing on her HP panel. Her husband did, though. So let me tell you, these antigen panels, these antibody panels, it's simply a measure of exposure, right? Has your immune system been exposed? Have you been exposed to this stuff, and have you developed an antibody response? It's not even necessarily an indicator of disease, right? These are actually the antigens that she reacts to. I can tell you to date, and again, this is research, so you can't hold me to it, but to date, for those patients for which we have found a positive antibody response on a standard HP panel, there's no overlap with any of the antigens for which they test positive from the samples that I collected in their homes or in their workplaces or in their environment. So what does that tell you? That tells you that indeed they have been exposed to that antigen at some point, but is it the relevant antigen in their disease? Maybe, maybe not, perhaps not, okay? So again, all I'm trying to say, I'm not knocking HP panels, although I'm kind of knocking HP panels through no fault of their own, but it's really, really challenging to identify the antigen that's associated with the disease. So results of our study, 45% of study subjects are positive to one or more antigen on the HP panel. This can be problematic because in the medical literature it suggests that you should only be reacting to one thing. I don't know whether or not results of our study are going to change that. And again, overlap between our positive antigen on the HP panel and that collected in the home is zero at this point. Could change. I'm sure it will at some point. So remember our patient, right? Because she has a love of gardening, we found antigen in her garden for which she reacted to. We also found antigen in the samples that I collected from the farm, in the silo, in the hayloft, and in the chicken coops, for which she tests positive. Amazingly enough, there was 100% crossover between the two in terms of identification of antigen. And I called her and I said, so, we're finding these antigens, two separate locations. They're the same antigen, so this is good. But how are you currently exposed to what it was that you were exposed to at the farm? Oh, we took silage and straw and chopped it to use for mulch. I've got 50 bags of this mulch in my garage, and every couple times a year we incorporate it into the soil to amend the soil. So we identified her source antigens, the sources of exposures, came up with an exposure avoidance minimization plan, and while she had chronic disease, we were able to stabilize her disease. She was able to come off of her immunosuppressant drugs. We gave her tips. She was still able to garden, do some of the gardening. We got rid of the mulch, right? Had her neighbor boy hired him to do some of the things, but she was able to become stable. Other locations where we often find stuff, and it's not up here because for some reason lately I've been finding things, bacteria that's growing in sump pump crocks. Why is that? Why would somebody be exposed to that? Sump pumps are typically in basements, sitting not too far away from the furnace. Furnace draws in return air, which comes across the floor of the basement and then gets blasted out through the house. But we find stuff in kitchens, living and family rooms, bathrooms. Vacuum cleaner samples are a good one. Furnace filters, garden, lawn, outdoor samples, some in the workplace. So essentially all over the place, right? So do I ever not collect a sample for which a patient reacts? Yes. And why does that happen? Sometimes I'm there in the wrong season. Antigen for which they react comes out in the fall or is more predominant in the spring, and I'm there in opposite seasons. It's absolutely possible that if an antigen is sitting on that chair, I'm 3 feet to the right of it when I collect. But repeat sampling really helps increase our probability of finding antigen. It's also possible that they're just not exposed anymore. Had a patient that was a very avid camper, loved to camp, had a camper, traveled all across the United States. She realized over time that she just didn't feel good anymore when she was camping. She had a hard time hiking. They didn't enjoy themselves anymore, so they sold the camper about couple weeks before I got there. So then I asked, have you ever had issues with water in the camper? Oh yeah, it was an old camper. Okay, did you have mold growing in the camper? Oh yeah, and we would just clean it up, every time we went camping. So how are you feeling now that you've sold the camper? You know what, I feel pretty good. We can walk all over the place around here and there aren't any problems. So unbeknownst to them, they themselves identified what it was that was making them feel bad and stopped doing it, okay? Okay, so I am done, and I know I'm a bit over time. So I'm done with this part of the presentation if you have any questions. If you want to know how we figure out in patients that react to multiple antigens, which one it is, I can talk about that quickly. We just do another round of tests, lymphoproliferation, cytokine expression assays, which this in and of itself is a bit challenging because we use their antigen that's collected in their environment. And I will say, I skipped over a slide that to date, we have found over 30 antigens in patients' environment that have never been associated with HP in the medical literature. So, I think as many antigens as there are out there, given the right immune response, they could be associated with HP. So there will never, I don't believe, be a finite number of antigens that we're looking for or trying to test. Hence the personalized medicine approach to doing this. Okay, I'm sorry I ran over. I love this topic. Any questions? Yes.
I like to think ahead.
Okay.
Is it possible that future data from this study will lend to idiopathic pulmonary fibrosis, like understanding that more, or like I don't know, is there a link, is there not a link? I don't know.
So that's a really good question. So I have a colleague that has applied for what I call a piggyback grant on our grant that's looking for gene environment, it's a gene environment association study. And because so many of our patients, when I see them, they're like, well, I was diagnosed with IPF, idiopathic pulmonary fibrosis, but now I went for a second opinion and they think it's HP. And I mean, they're so closely tied together and difficult to distinguish that I'm hoping that some of the analysis that we're able to do, given the clinical data that we have from these patients in multiple years worth of data, will help perhaps tease some of that out.
It doesn't matter right now, but in 10 years,
Yes.
it might help us.
Yes. Yep. Yeah.
How does a patient get enrolled into this study, or how do you find your patients? Is it a doctor referral? Is it?
Typically, it's a doctor referral, a pulmonologist referral. So we work with doctors right now at U of M, at Spectrum, at Henry Ford, and at the DMC. However, we're not restricted to taking patients from those referral centers. So, this is one of the reasons why I really wanted to do this. If you've got patients that have been diagnosed with HP, I've got a business card. You can take my card. You can have them contact me directly. As long as they give me approval or authorization, I can contact their physicians and see if they meet our inclusion criteria, as we've done that before. So we are absolutely looking for patients to work with. So please send them my way. It's best if they're referred to us. I don't know if it's possible. I can send out a flyer to you. Perhaps you can distribute that will give the contact information. They can pass that on to their physicians, and their physicians can say, yeah, this might be good for you, or maybe not. But I'm absolutely happy. I would be thrilled to do that. Yeah.
If it's so difficult to diagnose
Mm-hmm.
And the only thing that a pulmonologist has lab-wise is
Mhm.
that HP panel.
Mm-hmm. Where do we go from there?
How do you diagnose them?
So that's the whole purpose of our study, is essentially to see if having an exposure assessment person out in the field, so having sort of myself as a tool for a pulmonologist to use, increases the ability to identify the offending antigen. So my hope, and again, this is research, but my hope, and so far our numbers are good, but my hope is that sort of a service such as this is beneficial, is useful. There are a lot of people just like me out there that have been trained exposure scientists. If we're somebody that pulmonologists could tap into to do this work, then they've got boots on the ground. And that's what the pulmonologists that I work with right now really appreciate, because even if we don't find offending antigen, I'm able to go back to the pulmonologist and say, this is what I'm seeing in their home or not seeing. This is what I'm seeing in their environment or not seeing. These are some things that I think that we should, think about, or you should think about in terms of working with this patient or these patients. So, is this approach better than what they've got available to them right now? And hopefully it will be.
So sometimes is it they refer a patient to say, or refer a patient to you who say, well, I think they might have HP, but
Yeah.
I'm not sure.
Yeah.
The panel really isn't necessarily
Yeah.
showing that, so that's when they maybe would call you in and say, hey, see if you can find something.
Right now, pulmonologists really don't believe in the utility of the panels. They have nothing else to go on, but they really don't, in my conversation with them, they really don't believe in the utility of the panels. Because again, if they get a positive result on a panel for, say, Aspergillus, where is it in the patient's environment? Is it a current exposure? Or was it something that they were exposed to 15 years ago, and they've got memory cells, and they've got, they're still responding to it. So there's what caused the development of disease in the first place, or incited their hypersensitivity response, versus what are they currently exposed to that is, is continuing to result in these clinical signs, symptoms, development, or worsening of disease. It's really tough, right? It's really tough and incredibly frustrating for the patients. Yes, thank you. Thank you.